name is Osu Dama, and this afternoon we're going to talk briefly about local anesthetics. I'm an anesthetist at college. We'll be defining what local anesthetics are, structure and then classification, then their mechanism of action, their pharmaco, and then systemic from local anesthetics, how to manage them. Then we'll briefly also go through spinal, because apparently the topic is local anesthetics, spinal anesthesia. So let's see. Anesthetics. These are basically drugs that we anesthetists use a lot, and it's not only us. Most of our colleagues, surgeons that need to operate, also do use them. Usually these drugs block impulse transmission, and the blockade is reversible. It's not permanent. So they block impulses from being transmitted along these nerves and then other excitable tissues. Their structure, you need to know that there are three main parts of their structure. They have an aromatic or a benzene ring portion, and then an intermediate chain, and then an amine group side. So if you look at this side is the aromatic or the benzene portion of the structure. That's the intermediate chain, and then that's the amine group side. Usually it's the aromatic chain that affords these local anesthetics their lipophilic ability. And then the amine side affords them their hydrophilic properties. And then the amine side, if you look at it from this, you can see that there's a nitrogen here which has 3 bonds. But then you know the nitrogen can actually have a 4th bond. So it means this particular nitrogen can actually be protonated. So they can accept hydrogen ions, for instance, and then that can afford a local anesthetic a charge. And it can also lose the hydrogen ion if it has it, so that it becomes uncharged, because these are basic properties that you need to understand. Then you can appreciate their mechanism of actions a lot. And then the intermediate chain is also important because it gives them the anesthetic distinctiveness, because usually we'll put them as basically either esters or amides, and that comes from the intermediate chain structure. So you can classify them based on the structure if you are using the intermediate chain as an amide or an ester. You can also use their duration of action. In that case, you can have those that are short acting, intermediate acting, or long duration of action. And then their potency, that can also be used. So based on the structure, as I said, you have the esters and then the amides. The common ester that probably you need to know is cocaine, but in clinical practice we don't even use them as an local anesthetic anymore. It used to be used in ENT and others, but now they don't use them anymore. But then the amides, they are the common ones that you can come across, and the ones we have in our setting are basically lidocaine and then bupivacaine. Bupivacaine is what you sometimes call marcaine. So it's the same thing. There's a plain marcaine and a heavy marcaine. So it's not just heavy marcaine. All the marcaines are actually bupivacaine. The esters, they are quite short in their duration of action, and then they produce a bit of less intense analgesia. not as intense as what the amides will do. And they commonly cause hypersensitivity reactions. They are broken down by the plasma cholinesterase as compared to the liver microsomal enzymes that breaks down the amides. And rarely do you find these esters in use, as you saw from the earlier charts. They are not commonly used these days for anything. Commonly we use the amides, and these don't cause the hypersensitivity reactions. With the duration of action, if you look at short-acting ones, you're looking at between 20 to about 25 minutes, and the examples of those that are short-acting are there. With the intermediate-acting ones, you have our lidocaine there, which acts for about 45 to 60 minutes, and then the long-acting ones, we have our Marcaine in there, which acts for about 2 to 3 hours. Okay, so what this means is that if you're going to use Marcaine for a spinal and your surgical duration is, you are anticipating about 4 hours, spinal will not be a good thing to do, because, of course, after about 3 hours, you expect that to one off. And then you look at the duration to here. This table is giving you the concentrations that they commonly come in with. And our lidocaine, what we have now is about 2%, but at times we do get some 1% too. When it's 2%, all it means is if you just multiply it by 10, you get 20. So it's 20 milligram per ml. So anytime you take 1 ml of it, it's 20 milligram. If you have 1% lidocaine, then that is 10 milligram per ml. Because you know, at times you may use these local anesthetics, especially lidocaine, for treating some arrhythmias. If you are somewhere and you need to use them, you must know how much you have to use. So you must know the concentration and understand them. So that is what the percentages translate. You just multiply it by 10, then you get the actual milligram per ml. So if you know the dose per weight, you can always calculate and give as you want. So lidocaine, intermediate acting in duration, as I said, the common one we have is about 2%. You can give a maximum dose of about 300 milligrams. Okay, the duration is still there. And you can see, if you look at the doses we are given, it's been put into two, plain and then those with epinephrine or adrenaline. Epinephrine is same as adrenaline. Okay. So usually some of these local anesthetics, we add adrenaline to them. And when you have that, it actually prolongs its duration of action. We'll come to that, because what it does is if you infiltrate it and it contains adrenaline, then adrenaline will cause vasoconstriction of the local vessels, so that the drug kind of acts like a depot. It doesn't get diffused away faster. It stays there, then you have a prolonged duration in action. So you can actually add adrenaline to them. And when you add adrenaline to them, you can see that the maximum doses, if you add adrenaline, the doses actually goes up. Because if you add adrenaline, then because the drug doesn't get out of the site of injection quickly, it reduces the chances that it will be absorbed into the systemic circulation, and for that matter, toxicity. So you are allowed a much higher dose if you choose the one with what? Adrenaline. So that is why you see these doses quite higher compared to the plain ones if you are using them. Okay. With the potency, then this will also be linked to how faster your local anesthetic actually initiates a block. Once it initiates a block, immediately you put it there. That means it's very potent. And this is to do with its lipid solubility. Because if it's more lipid soluble, then you know it can easily permeate the lipid bilayer membrane, and for that matter, cause a blockade. And usually, if it's going to be lipid soluble, then you want more of the local anesthetics to be uncharged. Because if it's charged, then it's polar. So it cannot cross the lipid bilayer. Okay, so you know from basis fixes that if your pKa is very close to the pH of the surrounding media, then you have most of your dissociated weak base or acids being in a form of like the basic in an uncharged form. So if the pKa of the local anesthetic is very close to the physiological pH, then you have more of it in the unionized form, and therefore they can easily cross the lipid bilayer and then initiate the blockade for you. This is very theoretical. Practically not so, because there are some like Blockade and stuff whose pKa's are quite far from the physiological pH, but then they are very, very potent. So theoretically, yes, this explains it, but then practically there are some exceptions. Data does not support this wholly. Now, so with potency, you can also have a look. These are their pKa's, and then as you come down, you see their potency increasing. Okay, and as their hydrophobicity increases, then their potency also increases. Now, properties of an ideal local anesthetic. What is an ideal local anesthetic? The local anesthetic's action must be reversible. It shouldn't be irritant. It shouldn't cause any allergic reaction. And it should give you a sufficient block for a sufficient duration for your surgery. And it should be potent, stable in solutions. At times you may want to dilute it with saline or water for injection. It should be stable in it. It shouldn't interfere with your tissue healing. Wherever you put it, you're going to perform some procedure. It shouldn't interfere with your healing. And then if it has a vasoconstrictor action, then you wouldn't even need to add what? An epinephrine or adrenaline. And the only one that has that property is actually cocaine. But then we don't use it anymore. And it shouldn't also be expensive, especially in our setting. Otherwise, we cannot buy them. So, what is the mechanism of action of a local anesthetic? There are several mechanisms, but this one, you may need to do this. Ideally, you give your local anesthetic, let's say you've infiltrated it from the skin, you expect it to cross the lipid bilayer. This is the lipid bilayer. You expect it to cross it. As we said earlier, you need it to be in the unionized form or in the lipid lavin form so that it can cross the lipid bilayer. So if you look at these two, the same cocaine, this is uncharged, this is charged. So this is what will cross the membrane. And when it crosses the membrane and gets into the inside portion of the membrane, then it gets protonated to become the charged form. And it is this charged form that will actually block this sodium channel and prevent sodiums from entering this channel to generate an action potential and transmit an impulse. So once it blocks it, then sodium cannot enter the inside of the cell and you cannot generate an action potential, and you have your anesthesia or an analgesia or what have you. So this is basically how they work. Okay, good. Basically, all these local anesthetics are used to treat pain and pain transmission. I believe you conversant with them. Usually from the periphery, you have your first order neuron, which is the red one. that comes to the spinal cord, and it goes to the dorsal root ganglion. From there, you may have some small interneuron, and then you have a second order neuron, which then leaves the spinal cord, actually crosses over to the opposite side. Okay, so you can see that maybe if you have a prick on this side, a little prick here, for instance, the transmission is actually going to go up through the opposite side, or the contralateral side. It goes up through the spinothalamic tract, and this is spinothalamic means from the spine to the thalamus, and that is your second order neuron. Then from the thalamus, that is where you have the other fibers that will leave the thalamus to the other specialized areas of your brain to cause you to perceive the pain. So this is basically what we do. So you can interfere you can use your local anesthetics to interfere pain transmission, either by blocking this first order neuron or by blocking the second order neuron. Usually we don't do it from top, but you can also do it from top, because some of the IV pain reliefs that we give and some IV local anesthetics, these are people that are even giving lidocaine IV to treat chronic pain, and most of it actually works from top. It can actually affect the third order neurons, so you can block it at any of these levels. Okay. Now, what factors will affect the onset of your nerve block? The size of the nerve that you are blocking itself will affect the onset of your block. Whether the nerve is myelinated or not will also affect it. And then the firing frequency. Okay. Small fibers are usually blocked easier compared to bigger fibers. In other words, if you have a very thick nerve, it's difficult for local anesthetics to block it early compared to if you have a smaller fibers. Okay, because then with smaller fibers, the local anesthetic can easily cover it, let's assume it that way, or can easily move from one end of that small nerve to the other and block it completely, compared to if you have a bigger nerve. And then nerves too that have nodes of Ranvier, they come from nerves with myelin. So the myelin insulates your nerve and then leave small gaps on the nerve where you have no myelin. And usually these small gaps are what we call the nodes of Ranvier. And these small gaps are the conductive portions of the nerve where the myelin is totally insulated, so you can't depolarize and generate an action potential there. So for myelinated nerves, for instance, you can see that your impulses will jump from one node of Ranvier to another node of Ranvier. Okay, so if you have a nerve that is myelinated, once you block about 2 of the nodes of Ranvier, impulses beyond it is cut. You don't need to actually block the whole length of the nerve. Whilst those that don't have myelin, you may need to actually block the entire nerve to actually prevent transmission of an impulse. Okay, because the action potentials are always generated from the cell body and they travel towards the dendritic end of the nerves. So if you stop it from top by blocking the node of Ranvier from the top, you can't actually go down to generate an action potential. But for unmyelinated nerves, you can actually generate an action potential beyond your block. So you may have to block it all the way through. So if you look at this table, this is giving you the types of nerves, fibers, and then the onset of action and their sensitivity to block if you use local anesthetics. Usually, for pain, we'll be looking at two main fibers, the C fibers and then the A delta fibers. They are the fibers that are involved in pain transmission. C is unmyelinated, A delta is myelinated. Okay, and you can see that with the size, A delta is a bit bigger than C fibers. Okay, so if you look at the table, it's self-explanatory. You can go on and do that. Also, the pH of the medium in which you are injecting your local anesthetic can also affect your onset of block, because the pH will affect the pH of the local anesthetic eventually. So usually local anesthetics are injected into an acidic medium. If you inject it there, the onset will be what? Delayed. Because why will the onset be delayed if you inject it in an acidic medium? It will be protonated and it will be ionized, it will be charged, and for that matter, it cannot cross the bilayer membrane, so you cannot. So if you have, let's say, an abscess, for instance, if you say you are going to drain an abscess with a local infiltration, you don't know what you are doing, because it won't work. It won't work, because the whole area around it where you're going to is acidic. The local anesthetic will not work. So those are some of the few things. And then if acidic medium will not make it work, then alkalinization will make it work better. So at times, some people will intentionally add sodium bicarbonate to lidocaine or mercaine to use them for blocks for surgeries. All that can be done. We've already talked about the pKa and the physiological pH. Also, the molecular weight of the local anesthetic also matters. Smaller objects crosses the membrane easier compared to bigger objects. So smaller local anesthetic, smaller in terms of size, will cross the layer faster compared to bigger ones. And then we talked about lipid solubility too. Also protein binding. If the local anesthetic binds to protein, then it can't easily be released. So you kind of get it being released in slow form. So you get a very long duration of action. Okay, if it binds to protein. So clinical uses of local anesthetics. Infiltration. We are all familiar with it. And then topical, as well. The eye people uses it a lot. You can use it to specifically block specific nerves. So you identify the nerves, then you block them. That's a peripheral nerve block. With local infiltration, you're not actually blocking a specific nerve. You're just putting it all around, hoping that whichever nerve that comes there gets blocked. And then you can use them for spinal, epidurals, and caudal anesthesia. I've mentioned arrhythmia therapy with the use of lidocaine, for instance, and chronic pain. We talked about it. Chronic pain, not only IV lidocaine, but even epidurals for chronic pain. So that, and then the intravenous regional anesthesia, which is the BS block. Okay. The clinical preparation of local anesthetics. Local anesthetics are presented clinically as hydrochloride salts with a pH of about 5 to 6, and thus actually allows them to be dissolved in water and results in an acidic solution. Okay, but then when we inject it, because of the pH of our body, then it kind of alkalinizes it and then changes the pH, and it can cross the membrane. Lidocaine can be carbonated, which will make it basic, which will favor it in the unionized form. We can have preservative like the sodium metabisulfite, and at times even fungicides with them in those small dose vials ones. But then the multi-dose vials will have a meter parahydroxybenzoate in there. You can also combine two local anesthetics together, like the EMLA, which is an eutectic mixture of local anesthetics. That's the full name. It's usually a lidocaine and a prilocaine bind together. Usually this is a patch that we use to usually set IV lines on children. If you have it, you just put it on the side where you want to put your IV line. Give it some time, about 30 minutes, just take it off. The place is all numbed and you can set your line free. Two local anesthetics actually put together there. You can also add adrenaline. The surgeons do it a lot. They want local anesthetics with adrenaline so that they can give a lot of it and then have enough time to not only adrenaline, you can even add phenylephrine, also clonidine, which is an alpha-1 agonist receptor. You can also add it, and then bicarbonate, of course, to make it basic, to increase its form, and then the heavy bib that we mentioned. It's heavy in respect to CSF density. And that is because we've added dextrose to it, about 8.4% dextrose. So you can actually, that makes it heavy, so that when you put it in the subarachnoid space, or when you use it for spinal, then it kind of doesn't rise up too high, it sort of settles. So you can add glucose to it. And then others also add this hyaluronidase. This is like an enzyme, sort of, when you mix it with it, it kind of breaks down the tissues in the area and kind of ease the spread of your lidocaine or your local anesthetic. So that also helps. Okay, the pharmacokinetics option, basically from the site where you give it, and how much you absorb will depend on how much you've given. Okay, the pharmacokinetic properties of it, whether you added adrenaline or not, and then whether the place is also highly vascular or not. All this will affect how much that is absorbed into the system. Okay, and the plasma concentration will also vary depending on where you give it. There can also be a first pass pulmonary metabolism, which can limit the concentration of the local anesthetics, which can also reach the systemic toxicity. And then tissue distribution of the local anesthetics will be proportional to their lipid solubility. Of course, if it's highly lipid soluble, we expect it to go into tissues that are highly also lipid in nature. And then if there is a lot of blood supply to the infiltration site, that will also take it to some tissue. And then local anesthetic drugs, usually when you give them, they quickly get distributed to the brain, heart, liver, and lungs. And this is very important because this explains how the symptoms of local anesthetic systemic toxicity presents, because these are the tissues that takes a lot of it, and then the symptoms are basically from these places. And then they go slowly to the areas that have lower blood supply, like the muscles and then the fat. So the patient's age, the cardiovascular status, and the hepatic function of your patient, you must always take it into consideration when you using these local anesthetics. We said the MIs will be broken down by the liver with the cytochrome P450 enzyme, and then the esters will use the plasma cholinesterase or the pseudo-cholinesterase, and that is where the allergic reaction is coming from because of this PABA, which is para-aminobenzoic acid that is produced. The clearance The amide, because it's on the liver metabolism will affect it. So if your patient has an impaired liver function and you are using an amide, you should bear that in mind. And then once the liver metabolizes whatever metabolite that is formed, the kidney has to get rid of it. So kidney failure too could also be a problem. Okay. How do you prevent severe local anesthetic toxicity? The way to prevent it, do a regional block. And your regional block, you should always perform it in an area that is equipped to deal with cardiorespiratory collapse. And this is where we fall short. At times we think, oh, it's just lidocaine, and I'm just injecting it. Meanwhile, where you are, you don't even have an oxygen, you don't have an ambu bag, you don't have any airway device, you don't have any emergency drug to use to resuscitate this patient. You just put the patient on the table anyway, get lidocaine, and you are gone. If you are unlucky and your drugs get absorbed into the systemic circulation, it will be disastrous. Also, the age, weight, and conditions of your patient should always be taken into account when you are using them. Don't just look at the doses. Oh, I can give about 300 milligrams of lidocaine without adrenaline. I can give about 600, so let me just give it. Maybe you're giving that in a very frail adult. You must bear that in mind so that you adjust your doses. Also, your syringes of your local anesthetics and peridural and epidural infusions, you should label them clearly. There have been times people have picked epidural top-ups, which are actually bupivacaine, and giving them IV accidentally, and it's happened severally. So these are inexcusable. You have to label your syringes clearly, state what they are and whatever concentrations you have in them. And anytime you are injecting a local anesthetic, please make sure you aspirate, gentle aspiration. If you don't aspirate blood, it means you are not in a vessel, you are safe. And keep aspirating as you go along. Don't just aspirate once, nothing comes, and then you stop. But you must always bear in mind that, yes, you may not get anything, but still your local anesthetic can be what absorbed into the circulation. So perform your procedures, having all the needed equipment that you need to manage an emergency available. Both during and after drug administration, whoever, be it myself or you must keep talking to the patient. And that's the good thing about doing local. You can always converse with your patient to see how the patient is, or how are you okay? As you go along the surgery, if you don't have an anesthetist, you must do that yourself as you do the surgery. And then an appropriate test dose should also be given. For instance, if you do epidural, it affords you to give a test dose. Even when you do local nerve blocks, peripheral nerve blocks, you always give some test dose to see whether you have any changes. If you are even using a nerve stimulator, to see whether you have any damping of the amplitude of your current, then you're sure you are closer to the nerve, nowhere else, before you subsequently give. Don't just draw 20 cc lidocaine. You put the needle there, you aspirate, nothing comes, then the whole 20 goes once. That's not good. And then, if you have these days ultrasound can just identify all the specific nerve that supplies a specific area for you to block, so that you don't block everything. But if you are blocking everything, then you end up using higher volumes and higher concentrations. Then the chances that you have toxicity comes into play. How do you manage these systemic toxicities if they happen? must recognize them, and then immediate treatment, management, treatment, and then your follow-up. If you look at the recognition, you can see that it actually is to do with the systems where the drugs are usually absorbed into. And it starts from the brain, the CNS. The patient starts telling you, I'm having some numbness around my mouth. And gradually you're talking to the patient, is the numbness gone? Then he's like, now it's like your patient is not making sense. He's becoming confused, agitated, and then gradually, if you don't attend to this patient, very soon he will lose consciousness. At times, he may even have some seizures before loss of consciousness. With your cardiovascular system, you may have bradycardia if you have an ECG on. A lot of conduction blocks, and this happens a lot. Most surgeons, when they are doing their locals, they don't want the anesthetist to be there. They know why. I don't know. They've given, and it does. You will be there. They will come and call you. Where's the anesthetist? Where's the anesthetist? The patient is dying. You are calling the anesthetist, and it happens all the time. But they never learn. It's such a thing. At times, not even a single IV cannulation, even because it's a local. I mean, you get there and so please. Then, how do you manage it? You have to stop. If you are still giving it, stop. And then when you stop, like the surgeons will do, call for help. But maybe where you are, you may not have anybody to call, or probably the person is even home. Before he comes, the patient will be gone. So you must know what to do. Then you have to maintain your airway, and if possible, secure it. I'm sure Dr. O will take you through BLS and other things. He will teach you how to maintain the airway. Simple triple maneuver: head tilt, chin lift, jaw thrust. It's enough if you do it well in most cases to maintain your patient's airway. If that doesn't work and you think the patient is still conscious, just put in a nasopharyngeal airway. If your patient is unconscious and you have an oral airway, add it to it. These simple techniques will always maintain the patient's airway for you. And give the patient oxygen, 100%. If you have an ambu bag and your patient is not breathing well, once you are giving 100% oxygen, you have been able to open the airway. You can bag with an ambu bag. Maybe you cannot intubate, so pass you what you called already before the person comes. Then he will come and help you. But these simple things you should be able to do. If you haven't put in an IV cannulation from the beginning, please do, because you are going to need it. If your patient has seizures, you must abort them. The commonest drugs, we have the diazepam, midazolam. You can use this fairly, they are safe. But please, paliperidone, propofol can also stop them. But I will advise you not to use them, because if you start using these drugs and you don't have a means of ventilating your patient, you may be doing them more harm than good. Because if you give it to them and they become totally apneic and you are not skilled in taking care of the airway, it will be disastrous. Just use your midazolam, diazepam freely. Most of them will abort your seizures. Assess your patient's cardiovascular status. If he's in shock, let your fluids run. And then you can take blood for analysis for any definitive treatment that you need to do. So if you have a cardiopulmonary arrest, you have to start your CPR. If you have any arrhythmias, please manage them. But this is not where you go and use lidocaine to treat your arrhythmias. Remember, local anesthetics, once you add them, their toxicities are also what? Additive. So even though whatever arrhythmia you may be getting may be treatable with lidocaine, it's the same local anesthetic or a different local anesthetic causing the same problem. Don't add that on. It will worsen your problem. And they talk about this lipid emulsion, which is good. If you have it, you can give, because the lipid itself can actually mop up the local anesthetic from the vascular system. So if you have it, you can infuse. And that is why people will probably rush and use propofol. But remember Michael Jackson, apnea, the patient can die. Okay, propofol contains lipid. So people think when they use it in this sense, it's better, but the patient can. And that one small amount, and the patient is apneic at times on you. So you have to know how to use it. The patients, when they get into this state, it's difficult resuscitating them. But you can virtually get them back. Because remember, if it's an ester, the body will break it down. The pseudocholinesterase will break it down. If it's anemide, the liver will deal with it. So even if you don't do anything, it will eventually get out of the system. But it takes quite a while before they recover. So don't give up. Though your efforts may appear a bit futile, but don't give up. If they are hypotensive, manage it. And if you are able to get them back and alive, don't forget to follow these patients up. Okay, it's very important. So let's look at spinal anesthesia, which is one of the common things that you guys do. And we use the local anesthetic for that same purpose. So spinal anesthesia is where you introduce your local anesthetic into the subarachnoid space to block your spinal nerve. And thus is also temporary, because you don't want it to be what? Permanent. Okay. So you put your local anesthetic in your CSF. Usually, the spinal needle, you put it from the back here all the way into the subarachnoid space. So you go through the skin, then the supraspinous ligament, then the ligament which is in between the spinous process, which is the interspinous. Then you come to the ligamentum flavum. Immediately after the ligamentum flavum is the epidural space. And then after you puncture the dura, and then you are in the subarachnoid space. And what tells you that you are in the subarachnoid space is that CSF starts coming through your needle. Once you see it, you can give your local anesthetic. Please, the local anesthetic of choice for spinal is heavy bupivacaine. And this is very important. Don't use plain bupivacaine. Use them, but used by the SP. Bupivacaine, because it is heavier than CSF. When you put it in CSF, it settles. So you don't get a high, the chances that you get a very high block is very less things than the CSF. You put it in there and it's rising all the way up. And at times it can come, you can get blocks up to the neck. What will you do? The patient will not be breathing. You see, at times, even when we give spinal, you see the patient starts throwing out, they cannot breathe and all that. So stick to, if you do spinals yourself, which I know some of you may do, use heavy bupivacaine, not a plain bupivacaine. And note that the spinal, you are allowed to do it. The safest place to do it is L4, L5, and then L3, L4. These two spaces. L4, L5, L4, L3, L4. So between between L3, L4, and then between L4 and L5. Because the cord ends at where we say L1, 2 in adults, but in children it comes down a bit. But there are people who are variants. Some of them, the cord come a bit down. So between 2 and 3, it's not safe for everybody. You can do it, but it's not safe for everybody. But if you stick between 3 and 4, and then 4 and 5, that is fairly safe. So you can give your injection here and have your spinal anesthesia. Use spinal anesthesia, you can use it for any procedure below the umbilicus. If you want to amputate somebody's leg, size what? Once do TH, cesarean, hernias, anything below the umbilicus, you can use spinal anesthesia for. The agents, we say heavy, bupivacaine. Forget about adding adrenaline and other things. They can be done, but don't attempt it. Just use a heavy bupivacaine. You can at times add opioids. Yes, somebody has jumped morphine, but if I were you, I'll never use morphine, because I can even count the number of times I've used morphine for spinal. Morphine for spinal is quite common. I know why you mention morphine. It's common among our CREs, but not us. Someone asked me that question, that why is that you, the consultant, you don't use morphine for spinal, but then the CREs everywhere use. And I say, yeah, because they don't know and understand what they are doing. That's the basic reason, because we know the possible complications that can come from that. And if we are not ready to handle it, we'll leave it. But opioids like fentanyl, it's very safe. You can use it, about 20-25 micrograms. You can add it, and that is very safe. Morphine, if you're going to use it, ideally you should monitor your patients after you give spinal morphine for about 20, because you can have a delayed respiratory arrest even after 12 hours of spinal morphine. Yes, but and most of the point is you can do 2,000 cases, or maybe 10,000, and only one will have that problem and come and die. But if this one was elsewhere, it would have been a different thing. So that is the problem. They get a good pain relief from it, but because of those problems, we tend to avoid it. Because we don't have recovery services to monitor patients for 12 hours, 24 hours with monitors on the ward. No, even in Kolebu, we don't have that. So why should you do it? I do spinal morphines at times, but I never go above a 0.2. Yes, so if your CRAs want to use morphine and you are okay with it, advise them. They should never go above 0.2 milligrams. Yes, 0.2 milligrams of morphine. He's saying that's too small, but that is the safest. About between 20 to 30 micrograms you can add every of them. Yes, but then it's safer for your patient. It's safer because we've seen few patients with spinal morphine who have arrested and they all die. That is the thing. Once it happens, they will die because it's not noticed early. You mix it, you finish the case, the patient is fine. Hours later, then the problem. So you just find the patient in a bad state, or you don't even notice it at all, just brought him dead after surgery. It's how it is. So, no, brought him dead after surgery. So, fentanyl is safer, so you can use that. Okay. The physiological effects of your spinal, your neural block. And this is very important. Whenever you do a spinal, the nerves get blocked sequence. And I'm sure you are very familiar with this, that most of the time when I do a spinal, raise your legs. And let me see, once the patient is not able to raise the leg, then it means the spine working. Or legs, the patient, legs, if he does that, the patient keeps raising, sit up, then, isn't it? That is dangerous, because if you look at the sequence of the blockade, it starts with a sympathetic block. That's why at times when you immediately the patient lies down, or even before they lie down, you see that is running because the blood pressure up. At that time, raise the spinal is working. If you repeat a spinal again at this stage, you can imagine what you will get. Okay, so that alone, the drop in your blood pressure, and at times it comes with a bit of like a compensatory response. But then, because you have put heavy mercury in the spinal fluid, it kind of climbs up a bit as well, and that can come to about T level and get some of the cardiac fibers. So most of the time, you see bradycardia associated with this. And when you see that, it means your hypertension is very worse. Your spinal has really gone up and up. Okay. See, and that is what I'm saying. How did the person test to see that it's not working? If you do that, that is the last nerve that is going to be involved in the blockade. So maybe your spinal is not there yet. So if you have changes in your sympathetic system, it means your spinal is working. Even if the patient is raising the legs, hold on. And then after the sympathetics, the next thing is what? Pain and temperature. And in fact, temperature gets blocked before pain. If you are not even going to use your autonomic changes to test whether your spinal is working, the next thing is to use a nice block to check your dermatomes to see if the patient can feel whether it's cold or not cold or something. That is better than saying break. And if that works, then you can move on to the pain. Use a needle to just prick the patient dermatome by dermatome gradually to check to see where your block is. And then it follows all the way to the motor. And when she's recovering spinal, she recovers in a reverse order. Okay. Always note that if you check for, let's say, pain, and your pain is at T10, your temperature block is about 2 to 3 sensory levels above this, and your autonomic block will be about 2 to 3 sensory levels above the temperature. So if you test with, let's say, an ice block, you have a block of, let's say, T cells. What it means is that your autonomics will actually come all the way up, and that is not good. So you can have issues with your blood pressure, your heart rate, and stuff, because the levels are usually about 2 to 3 above each other. Okay. You cannot see it. Don't worry. Very short notice for us, so don't mind me. Then the above sequence of neural blockade occurs, and this is because we did talk about the nerve fibers, their sizes, the fact that the smaller the size, the easier it is nerve to be blocked, and then whether it is myelinated or not, the faster it is when it's myelinated to be blocked. All that explains why we get that You know about hypotension occurring when you give a spinal, and I've already explained why you could have bradycardia when your block is about T4 as well. Your respiratory system can also be involved. I'm sure you've witnessed the fact that at times of spinal, the patient have difficulty with breathing. The phrenic quite high up to catch it to the diaphragm. You may not catch it easy. In fact, if your spinal gets to this level, you will have a high spinal. And for that patient, you have to intubate this patient immediately because he cannot breathe. But most of the time, it's the intercostal nerves that you catch them early, their respiration a bit. Once you can use your bed tilt a bit to help you because the drug is heavy, so you expect it to settle with gravity. So if you think your level of block is too high, you can raise the patient's head. Okay, and then it will kind of with gravity to go down and reduce the highness of the block for you. If you think the block is up, you can give the patient a head down. But don't forget that the head down means the drug is coming up to the head. So don't give a head down for a very long duration because you may end up having a high spinal from that. These are other effects from your spinal. The bladder, because of the sacral blockade, you get atonic bladder. And that is why at times some people suggest or say that when you do spinal, you have to, and you're going to give the patient fluids, yes, put in the catheter so that you empty the bladder for them, because otherwise it will be very distended. Okay. Now, as for these indications for spinal, you know them already, so I'm not going to bore you with it. But contraindications for spinal, in which patients will you be very careful doing a spinal, or which patient will you not do spinal for? Of course, if your patient does not consent, you cannot do a spinal for. Also, remember you're going to do the of the patient in there. You can't do it because your needle will carry this infection into the CSF. The patient can develop what? Meningitis and all that. Infection at the site. If you have even sepsis, spinal is not advised because on your way subarachnoid space, you get to the space before you puncture the dura. The epidural space, you have some vessels there. You may puncture them, and then what are you carrying from the blood stream into the subarachnoid space? Same infection. So even sepsis, people say don't do that. If your patient is allergic to the heavy bupivacaine, this you can only get if you have a previous history of it. Otherwise, you won't know. And then patients with increased intracranial pressure, we all know about it because of possibility of what? Coning. Because when you do a spinal, you puncture the dura, you make a hole in it, CSF starts leaking, you reduce the pressure in the subarachnoid space, and quite also the pressure up go down. So you don't do that in such patients. If your patient has severe hypovolemia, and this is very important, you must tell your CRS because okay, they do, but it's wrong. Yes, you see, it is totally wrong. You see, most of the patients may survive it, but that one patient, and I've seen one patient, newly married, ectopic, had spinal, arrested. The woman survived. We managed to let her live, but probably we should have let her die. She went home as a vegetable with a young couple. What is the husband going to do with this woman? As a vegetable. Yes. And that is the thing, because spinal will give you hypotension. So, people will do spinals for previous. It is dangerous, even though they may not be bleeding. But intra-op, they can bleed so much, at times to the extent that you may even have to do hysterectomy for some of them. So it's a wrong principle. Abruptious, if it's marginal, but not. So all your patients who are likely to have hypovolemia, it's a wrong thing. You see, if it's on, you can do spinal, but you and I know ectopic can rupture anytime. At times, even after the spinal, the patient is lying down. Before you clean the abdomen and open up, the abdomen is full of blood, and already the sympathetic interference will worsen the hypotension. You may not even have blood. What have you done? So that's the thing. Make the technique safe from the beginning. Then if you go to pop, then you have no issues. But if you don't make the technique safe from the beginning and your holes can be punctured in it, you cannot stand and defend it anywhere if you have issues. Okay. You have patients with aortic and mitral stenosis. These patients have fixed cardiac output. They cannot change their cardiac output. No matter what you do, you cannot change their cardiac output. So if you go interfering in their sympathetics and their blood pressure drops, no matter fluid amount you give, the vasopressors you give, you cannot increase their cardiac output, and therefore their blood pressures will collapse and they will arrest on you. So as much as possible, don't do spinals in them. And the other relative contraindications, but even these relative ones, things like patients with coagulating disorders, we have our severe preeclampsias that come. At times you do a bedside clotting, it's 10 minutes, 15 minutes. Don't do a spinal in them. Yeah, it is 50, 60. Don't do a spinal in them, because the problem with them is that they are not going to bleed out and die, but then they can bleed into the the epidural space, and if they do, that clot can compress on the spinal cord and cause them to be paralyzed. And if such a thing happens and you don't actually decompress this clot within some few hours, they will be paralyzed forever. So the spinal is found to be easier. That is what others see. But what goes into it is not that easy. It must be a right technique from the onset. And then some of your patients may have back problems. If they have back problems, absolute by relative, because even you, the one doing the spinal, it will be difficult for you. At times too, they may have neurologic problems. You will stick a needle at their back, and then they will come and say, you have caused it. Yesterday I did a spinal for a woman. She insisted she wants a spinal. I said no, because she had this chronic long-standing back pain, and she said she wants a spinal because she had a spinal before and she loved it. So, well, I noted it down, and that is her wish. I gave her the spinal. This morning, she was complaining of severe backache, and there's nothing I can do about it. Yes, you knew it, you were told, but you wanted it. But those are some of the problems. This one, if it's not because I know, this woman can go turn around and say it's the injection I gave, and she will have the chronic back pain. Any neurosurgeon that has said this woman will say she has a chronic back pain. How do I say I'm not the one who caused it? I have stuck a little there. That is a complication. we'll come to that. That's a complication from the spinal. Okay. So, in doing a spinal anesthesia, you must prepare your pre-medicate them with midazolam, which we usually do. IV assess before you put a spinal in. There's nothing like a small spinal. Because of the, you see, you are laughing because you know, give me, they will go, they tell the anesthetic, give me some spinal, let me do this. It's not a small spinal. So get your IV line in, rehydrate them, because when your blood pressures are falling, you need to give them what? IV fluids. So get your, please make sure you have monitoring. ECG, blood pressure, SPO, and possibly temperature. These are the 4 monitoring. And all your patients, that whether it's a local infiltration, whatever, they must have these 4 basic, and then you can add on based on the complexity of the case that you are doing. But these 4 basic monitoring, they must all have. Good. And then, if you are going to do a spinal, prepare to do general anesthesia. So if you look at, it has no business actually performing a spinal in a patient, because the surgeon is not in a position to do what? General anesthesia. Because at times your spinal will fail, or you will have complications from it that will necessitate that you convert it to general anesthesia. If you cannot do it, how? And that means before you do the spinal, all your equipment and your drugs for general anesthesia, you must what? Have it. Otherwise, it's not safe. Don't actually. Great. Then you can use get out in there. Then you position them for your proceed. With the position, they can either be lateral or sitting. At times you can do them prone like this. These days, they're even doing back surgeries under spinal. Yes, so you put them, yeah, it's all written out there. So you put them like this, you do the spinal in this position, and then once it starts working, the surgeons go ahead and do their back surgery. I mean, technically speaking, if you're going to do L4, 5, or L3 to S1 decompressive laminectomy, spinal can give you anesthesia for that. But then, I don't know how comfortable it will be for your patient to lie in this position for all that period for the surgery. But I mean, it's done. So you can do it that way. So your patient can sit like this for you. How do you determine your space? You palpate your iliac crest, the two. You draw a horizontal line between the two, and that imaginary line will always go through the body of L4. So if you drop beneath this imaginary, should be between L4 and L5. If you go above this line, it should be between L3 and L4, and you are safe doing spinal in any of these 2 positions. You can also do your spinal on the side, but when you are going to do your spinal on the side, you must consider where the surgery is going to be done. Because remember, your drug is what? Heavy. So it will settle with what? Gravity. So if you're going to amputate somebody's left leg, for instance, the argument, there's no need blocking both legs. Why don't you just block the left leg alone? And because of gravity, and your drug is heavy, it means that if you're going to do the spinal on the side, then the patient must lie on the side of the pathology, so that you do the spinal in that position. And you can let the patient lie in that position for as long as you wish, so that the drug settles on that side. Usually the drugs get fixed after about 5 minutes. It doesn't move anymore. So you can lie in that position for about 5 minutes. Then you turn him to the back for them to do CDR. But all the time you will get some residual paralysis on the other leg as well. But you can do your spinal in the lateral position as well. The fact will affect the spread of the injected local anesthetic. Of course, the varicity. If it's heavy, it will settle in the CSF. If it's not, it's in the CSF. So, and then the position of the patient too. Okay, the patient is sitting, it goes down. At times you can do it, for instance, where if you're going to do perineal surgery, where you are only looking at the the sacral fibers, then you don't need to block. So in that case, you do the spinal, you let the patient sit for like 5-10 minutes so that the blood really settles in the perineum down to just give you a perineal block, and then you are good to go to do sex. You can do your fistulas, your hemorrhoidectomies all under saddle block without doing a spinal, and that is even safer. Then you interfere so much with your sympathetics too, and therefore your blood pressure. You avoid all those things. And then the concentration that you use, and then the volume. Talking about the volume and the concentration, you see the heavy Bupivacaine is 0.5%, and I'm sure you all know it's 4 mils. For a standard adult, we use about 3 mils of this for spinal. 3 mils. The heavy Bupivacaine. 3 mils. That is what we use. So when you get a patient, you can judge, because usually with the length of the spinal cord. Very tall people have a long spinal cord, so they may end up probably needing a bit more than 3. But shorter ones, like you may have to judge this 3 if you reduce it a little bit. Okay, that is for non-pregnant patients. For obstetric patients, they are more sensitive to the heavy Bupivacaine because of the gravid uterus and the hormonal changes in the epidural space. There is kind of pressure on the dura. So when you put any drug subarachnoid, it spreads very fast. So for them, that amount 3 is reduced to, comes to about 2 mils. Yes. So for them, 2 mils is safe. If you use 3 mils in obstetrics, the hypertension you will get and the bradycardia you will get, you will be shocked. So 2 mils is safe. And then if you want to add your fentanyl or whatever, but even that, in obstetrics you get a very short woman or something, you may even use 1.5, 1.8, thereabout. Okay, so put that also, keep that also, so that at least you know what to do. And then, of course, if you do the block very high, if you come all the way up and do a block, apart from you standing a chance that you enjoy the spinal cord, you will have a very high block, level of block as well. So the higher up, the chances that you have. And then the speed of injection, because you are putting the drug in a fluid and it's going to mix with it. So if you inject it all very fast, it mixes with it very fast and then rises. If you inject it slowly too, it goes slowly and settles, so you get a very lower block. And that is why at times you see some people, they will use, I'm sure you might have seen, they will use very small amount of the heavy Bupivacaine, but then they will draw some of the CSF into the syringe to mix with it. Then they will give it, because even though they are using a smaller amount, it can actually give them the level of block that they need, because they end up giving more volume, which will affect the spread, and therefore a good block, even though they use a small amount. So some that sabotage technique as well, and then that's it. So if you add your own, it gives you a very good analgesia, and it prolongs the duration of action of your local anesthetic as well as in your spinal. Let's quickly look at complications and then we end. With the complication, spinal hypertension is one. We've already explained it. How to manage the hypertension is to give what? Fluids. And these fluids, not only when the hypertension has occurred, but even before the spinal, what we usually call preloading. We give them about 500 of crystalloids. At times, some people will use of colloid just to expand the volume even before the spinal is done. And then after what? Fluids. If your hypertension is not responsive to these fluids, then you add the vasopressors. The commonest one you will find is what? Ephedrine. Use them. You can give 5 milligram boluses of it. Okay. Ephedrine. Boluses of it just to help build your blood pressure up. And always immediately after your spinal, because the sympathetics are the ones that get blocked first, it means immediately after your spinal, you must frequently check what? Your blood pressure. That's why some people, even immediately after the spinal, will put their hands on the patient's pulse and keep it there, because they know that is when they are likely to have what? Problems. Okay. You can have paresthesia happening, and then you can have a blood tap if you injure any vessel. Nausea and vomiting, most of this, you've seen it, is initiated by the hypertension. Okay. Total spinal, where you get your spinal go all the way up to your phrenic nerve, and then the patient cannot breathe. There's also backache in patients who do spinal a lot. And then you have the post-dural puncture headaches you did talk about. And this post-dural headaches is basically to do with the hole that you make in the dura with your needle. That hole, CSF keep leaking out, and the pressure in there drops. The brain sucks a bit. There's a pulling on the arachnoid villi, and then you get these kind of head. So more CSF you leak, the chances that you have these headaches. And that is why when they have them, we say they should lie flat, because gravity will make you lose more CSF through the hole that you've made. And then, but most of them lying flat, proper rehydration, good analgesics, the commonest ones. If it persists, you can add your gabapentin, once you can add them. Most of them do well on the usual common pain reliefs. Okay. Yes, it kind of drags from the dura, the covering, and that is what gives them the headaches. So you can manage. But if it's worse, I've actually done it. The patient had a spinal tumor, a pregnant woman, and had a bad headache. She couldn't even breastfeed the baby. If it persists and it's very worrying, then you can do what we call the epidural blood patch. So what you do is you do epidural, you don't do a spinal, you do epidural at the very space where you did the spinal. When you are in the epidural space, you stop, then you take the patient's own blood and you inject it through the epidural needle into the epidural space. This blood goes there, clots and seals the hole. Because once the hole seals, the headache stops. So some of them, immediately as you inject, they tell you the headache has stopped, then you stop. Or they get the radicular pain. You don't inject so much. The amount you inject to get the relief is small. It's small. So don't extend it to the coagulopathy patient. You won't get cord compression. But as you do this in most of the patients will respond to your conventional management without you necessarily do. And you don't do this early. You wait. Okay, you wait till you've done all that you should do, and then your patient responding, then you can do that. Of course, your infection, itis, and others are also good. So with the post-dural puncture headaches, you can see that it's to do with the hole that you make. So the bigger your spinal needle, the bigger the hole that you make, and therefore the chances that your patient will have a headache. So smaller spinal needles are always better than bigger. It's easier doing bigger needles because you can actually hold them and just put them there. But the smaller finer ones like 27 gauge is so difficult. So people prefer to use the bigger needles, but then the patients get the post-dural puncture headaches. Also, the spinal needles, there are two main. You have the pencil and then the bevel tip. If you look at our normal green needle, the needle on syringes, the tip is a bevel type. The pencil point tip is like this. These two, you see how that is. These are all pencil. It's a bevel tip. You see that these don't have a cutting edge, but this one has a cutting. So this one is actually easier to do a spinal with this one compared to the pen or the bevel cuts. So it's easy as you put the space and you've done your spinal. But these don't cut, they actually split the fibers. So in a sense, these don't actually make a hole. They just split the fibers. Once the needle comes off, the fibers come together and you don't have a permanent hole in the dura. So if you are procuring spinal needles for your hospital, the best option is to go for the pencil, but then it's difficult to use spinal with these in the less experience compared to if you have to use this. And then the incidence of having a post-dural puncture headache will be very less with these ones compared to that one. So these are the same thing of that's a spinal being done there for the patient. I hope we've been able to. It's quite an extensive one, but I hope we've covered. So please, I know some of the questions have come already, but if there are questions. You see, it can be meningitis. Don't forget that, because you've done a spinal, introduce an infection into the cerebral space. So the first thing is when they start complaining with the next loud meningitis, and your clinic sign, if they don't have those and they don't have fever, you sure you're dealing with a post-dural puncture headache. Then you manage it just as I said. But if you suspect it's meningitis, you have to manage it like you have meningitis, because it can't be meningitis. But it's a very terrible headache, especially if it comes from epidural, because epidural, the needle is far bigger than spinal. So if you accidentally puncture the dura with it, then you have a very terrible headache. But the good thing is they do very well with fluids, lying flat, and usual analgesics. The problem is that most of the patients are obstetric mothers, and you cannot ask them to lie in bed all the time. Okay. You see, we used to argue that if you get up too early after spinal, then you get these headaches, because the hole that we made in the dura has not been sealed. But these days, the needles we use for spinal, the biggest is about 25 gauge, which is very small. So now the argument from the patient sitting up early and stuff is not there. But then I can also tell you that practically, I've also noticed that patients who actually get up early are more likely to complain of these headaches. So my practice is that some of my colleagues don't do that. But what I do, I always advise my patients to, as much as possible, lie flat for about 6 hours after my spinal. Because even though it is not advised in literature, clinically, I've seen that those that do get up early are the ones that are more likely to have these headaches and complain. So I've always said, lie flat for 6 hours after the surgery before you get up. And I've seen that helps a lot. So you may do that, but as I said, literature says they can actually get up because you are using smaller spinal networks currently. Yes, they do, because in management of these post-dural contraindications, caffeine is one of the very effective drugs that is used. So anything that contains caffeine, in a way, helps. So yes, it helps with the pain management. Yes, yes. It doesn't prevent it, but then when they get it, if they take things that contain caffeine, it does.
I'm asking whether there is any role for the use of steroids or some of the neuroleptics like haloperidol in those that people will come to
No. Steroids do not help. What the Americans propagate is a drug that they claim can increase the CSF levels. So they use fluorescent a lot, which contains a barbitune, paracetamol, and then another drug. And then there is also a drug called somatotrypsin. That is also effective, but steroids have not actually been implicated in the use of post-dural contraindications.
I want to know about the subgroup. The subgroup, my understanding is the same as the level that you have to do. Except that you see the patient
for 5 to 10 minutes before you lie the patient down, so that your spinal is only you targeting the sacral plexus alone. Yes, the last one there. Local anesthetic system toxicity. Yes. We went through it. We said, but let me summarize. We said the first thing is for you to recognize. And with the recognition, we said you look at the organs that your local anesthetics are likely to spread into, and it starts from the brain. They start complaining with the circumoral numbness, the tingling, they become confused. Okay, they may have seizures, lose consciousness, CVS, they may have bradycardia, hypertension, all that. Okay. So in managing them, just like the way you manage anything, go through your ABC, you will need to maintain their airway. And I did talk about the simple triple maneuver, the use of oropharyngeal airway, nasopharyngeal airway, isn't it? Yes, and then giving them 100% oxygen. And in some cases, you may even have to tube them because they've lost consciousness. Okay, if they have seizures, you give them what? Your benzodiazepine. We did talk about drugs like haloperidol, propofol, which I advise that may not be good for you to use. And then we mentioned the lipid emulsion. Okay, and then we added that the management of these patients can be quite prolonged. So don't give up, because with time, the system will break these things down, either by the pseudocholinesterase or the liver system. So it's all in there, if you can.
first question. My colleague said, one of the things don't get it. I just tell that we are in charge. We are in charge at the head of the district.
Okay, I will just answer this last question. You see, you can repeat a spinal, but the point I make is that make sure you've gone through the proper testing procedure and you've satisfied yourself that the nerves that needed to be blocked at every time, none of them is blocked, and therefore your spinal, you might have injected or deposited your drug elsewhere other than subarachnoid. Then you can repeat it. Okay. But the issue of they being in charge of the head, you see, they are in charge of the head. But as a doctor, you are actually in charge of them. Because when things happen and you go to court with them, they will tell you that the law will say where there is no doctor anesthesia, actually the surgeon is the one who takes full responsibility for the patient. So, yeah, they are in charge of the head, but you are allowed to what? Advise them. And you must push that through if you think they are doing something wrong. And that is why you need to learn about some of these things and you yourself know it so that you can inform them accordingly. And I think some of these things is the way to do it. If you have a good rapport with your anesthetist and he knows you are not saying it to undermine him or her or to say he doesn't know what he's doing, in a nice way, he will probably understand what you are saying. And remember, most of them are actually not comfortable with general anesthesia. They are not comfortable, especially when it comes to airway issues. They are not comfortable at all. So everything they wish they can do spinal. And that is the problem. But there's a nice way you can approach these things. You see, there's no time interval, but have patience and go through all the nerves and check. Don't be in a hurry to repeat a spinal. That is what I will tell you.